pathologists in lung cancer, we are kind of the poster child of applying modern molecular diagnostic to use the tissue to treat our patients. But that has challenges because, in the last 20 years, the diagnostic of tumor has moved to obtain smaller and smaller samples. From surgical biopsy, we moved to core needle biopsy and then to fine needle aspiration, which is a cytology specimen. And that was considered okay because it was safer and better and faster for the patient. However, by having the challenge to use that material to obtain data on genomic changes, molecular changes, we had to revise what we were doing. So pathology, we realized that we get small material, and we have been advocating for tissue, core needle biopsies. But many times, in many practices, we get fine needle aspirations only, and that's a challenge. So what we have been doing as a community in the last, I would say, 10 years is to ask ourselves, how much tissue do we need to do the best histology diagnosis possible? And we try to minimize the use of that tissue. So histology is very important, immunohistochemistry and ancillary diagnosis to make the diagnosis of adenocarcinoma, squamous cell carcinoma, neuroendocarcinoma is important, but we don't need to run 5 immunohistochemistry markers for that. If we have a kind of a well-defined workflow, we can use 2, 3, and then the limited sample that we have, it could be even FNA in cytology smear, could be an FNA on a cell block or a small biopsy. We can use it for molecular testing for what I consider standard of care targeted therapy these days option, like EGFR mutation, ALK translocation, ROS1 translocation, and now the new MET exon 14 skip alteration.